Welcome to the Clinical Update podcast, a podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Pat Anderson, and I'm here with Dr Pipin Singh for this episode. Welcome, Pip.
Hi, Pat. Thanks for having me back.
So Pipin is a GP in Tyne and Wear, and I'll be talking to him today about the care of the often older people who live in nursing homes. This is obviously a complex area of care and one that's of interest to Pipin, as he'll explain. Pipin, you've written lots of learning materials for us and frequently spoken and chaired at our live events. So we're very glad to welcome you back to the podcast. And you'll be chairing and speaking for us on the 4th of December in Liverpool at MIMS Learning Live North. Can you just briefly say what you'll be talking about at that event?
Yeah, so as you said, I'll be chairing one of the streams in Liverpool and looking forward to that again. So thank you for having me back for that. Looking forward to talking about lipid management and the updates to some of the new lipid lowering agents that we are now using and have been using over the last sort of 12 months.
Great. And that is the topic of a previous podcast we've done with Pipin, which you can find on the MIMS Learning site or on podcast players. So today we're talking about nursing homes, and Pip, could you tell us why is the care of nursing home patients important to you?
Yeah, so I think it's often a cohort of patients that can be forgotten about. Patients in there are often fascinating. They often have a very individual story to tell, lots of years of wisdom and experience they often want to share. It's often more about communication style medicine as well. It's more of an art, I would say, than a science, where less medicine is more. I'll talk a little bit about that later on and what I mean by it. But certain things like de-prescribing can be very rewarding. End-of-life care can be particularly rewarding. And also just understanding how physiology changes in patients who develop moderate to severe frailty. So that can prove a little bit of a challenge, because often certain things that we do for a younger cohort of patients doesn't necessarily apply to the group of patients that are in care homes with more complex illnesses that are linked to frailty. And there are other challenges that frailty brings as well. So that's one of the reasons it's important to me that it's a very interesting group of patients to look after. And I take a big interest in, I'm the lead at my surgery for this, and look after a care home and do a weekly ward round with the care home that I look after.
Great. And how have you gone about, you say you're the lead in your practice now, how have you gone about building up your expertise in caring for this group of patients?
Sure. So, I mean, I think it's something that was of interest to me in my junior years when I was a junior doctor. So I did 3 care of the elderly jobs when I was an F1, F2 and ST1, bit of acute geriatrics, bit of rehabilitation geriatrics, and found that quite fascinating. And when I became a GP registrar, did a lot of visits within the care home, and when I became a GP and then subsequently a partner, I took on the role of a care home lead. So even prior to the contractual changes to do weekly ward rounds in care homes, we were proactively doing this work anyway. So I think it's been largely by doing, Pat, I would say, more than anything. We found that an individual clinician looking after the homes has reduced workflow throughout the week. It's improved continuity, so very rewarding for the patient, the clinician, and the nursing home team within the home, who find it great to have a point of contact to go to, someone that they can trust and rely on. And you get to know them, they get to know you, and it makes for a good working relationship. I also attend frailty meetings, so our PCN have quarterly frailty meetings, which I'm involved in setting up and setting the agenda for. And they're, as I've said, every quarter, and that involves the GPs within the PCN who look after care homes, but also our PCN pharmacists and also some of the wider MDT, which includes some of the nurses from the trust, safeguarding boards, and so forth. So again, that can make for a very interesting meeting where you share cases in those meetings, interesting cases that have gone well, maybe not so well, learning points, and we often do some topic-based teaching within that. And we also invite a care of the elderly consultant from our local hospital to come along and provide some wisdom if needed also.
That's brilliant. I mean, I'm aware that frailty is coming up the agenda, and for primary care, thinking about frailty is increasingly important. It's really interesting to hear that is being formally embodied at the PCN level.
Yes, yeah. If you are listening to this and you're not doing that as a PCN, that might be something to think about. Could you have a frailty lead, someone who takes charge, attends frailty meetings, any workshops, any feedback that they're willing to provide to the wider team? Can you set up a meeting and so forth? Because it is often very rewarding and you do learn quite a lot from each other, I would say, doing that.
To get a picture of what it means for the average GP, do we know how many people we've got in nursing or care homes and how many nursing home patients the average GP would be likely to see in a year?
Yeah, so I was looking this up earlier actually, and because I wasn't actually sure myself about the actual number of patients in a care home within the United Kingdom, and according to the government website, it is around about 420 to 450,000 patients at the present time. And I think our population sits at around 67, 68 million. So I worked that out to be around 0.8% of the population who live in a care home. I'm not sure whether that's split into nursing or residential care or so forth, but that's still a lot of people within the care home setting. And that's, as we know, that is only going to grow as our population ages over the next 10 to 20 years. And we know that's happening on a rapid basis. So the care home I look after, for example, has 50 beds within it, and I see around 10 to 15 of those patients a week. And that's generally a mixture of scheduled and unscheduled care. I personally tend to adopt a 5-weekly cycle. And again, I know GPs who are listening to this podcast today, or advanced nurse practitioners or other healthcare colleagues who will be listening, may do it slightly differently, but I personally tend to see the patients every 5 weeks. That basically means that at least everyone gets a review once every 5 weeks, and that allows for the scheduled and unscheduled care that I was just talking about, so it doesn't feel too overrun on a weekly basis, because they can get quite busy. Prior to the ward round setting up, unscheduled care was amounting to around 2 to 3 patients a day plus queries. So they may be medication queries or other queries. So the ward round often prevents queries coming throughout the week. So because I tend to mop up all of that on the ward round, so my colleagues won't get any of those queries coming through. So overall, it improves workflow and efficiency.
Minimises sort of toing and froing between the home and the practice. To a smaller extent, I guess some GPs are involved with residential homes that are for younger people that are not care of the elderly type nursing homes. Do you have any involvement with that, or are you more just the nursing home aspect?
So I'm not personally involved with disability units, although I am aware of GPs that are, particularly those who have a special interest in that area. I may look after patients occasionally with learning disabilities who are admitted to care homes. To say, for example, a patient may have Down syndrome but have developed a dementia.
Yeah.
Which we know dementia coexists with Down syndrome more frequently. And this involvement is often the same as I would have with other residents. So that would be routine reviews, unscheduled care if patients become unwell, communications with families and the patients, care planning. And depending on the specific disability, communication with the patients can be more challenging for obvious reasons, involving the relatives more, involving your local learning disability teams. Might tend to find that patients with learning disabilities are more prone to certain things like fits, for example. So there might be more medications that we need to manage there. And often patients with LD may have more complex behavioural challenges. And that might result in prescribing some antipsychotic, more sort of increases of antipsychotic medication throughout the daytime or the nighttime. So again, that will be the sort of thing that I'll be involved with any patients who are in the care home with a learning disability, and that will often be in conjunction with and working closely together with the learning disability teams and potentially also the mental health services for older people. So it requires a bit more of a multidisciplinary approach.
Is it perhaps more time consuming and you have a different consultation style?
So the short answer, yes, it can be time consuming, but it can also be very rewarding, as I've touched on earlier. And the continuity is absolutely critical, really. And the knowledge of the patients, I've been looking after my care home residents now for over 5+ years, and the knowledge of the patients makes things a lot easier. So continuity, by definition, really leads to efficiency. Just not needing to review the case notes every time I go out and see the patient, just purely because I've known maybe a certain patient for a couple of years. I know exactly what I've done. I know exactly their medical histories. I know potentially even what they want or what their families want if the patients don't have capacity. So that makes life a lot easier and avoids duplication of work where someone else may need to pick something up. For example, if there wasn't that continuity and not realise that something else has already been done, because it was done 6 months ago and the person hasn't had the chance to look back through the notes or whatever. But it's not a one-man job, Pat. It requires the help of practice pharmacist who I work very closely with to help me manage the medication side of things, who will also help me with structured medication reviews when patients arrive at the care home, and also reviewing medicines when patients maybe get admitted to hospital and then discharged with an updated list of medications where things may have been added, or more likely things have been stopped, which is more often the case in sort of older, frail patients. Also using your registrars and your F2s to share the workload for the experience. So we also look after a second care home, which one of my partners manages. And this last 12 months, he's been taking out our F2, who's been sharing the workload with him. So that gives the F2 experience in seeing the patients as well, and gives them that experience of frailty. So they've set that up where they share that workload together. So that's certain ways that you may wish to manage your time more efficiently when looking after sort of the care home residents. And I think also having a structure with the care home as to how you go about managing your ward round. So, for example, the way I do it, the list of patients that need reviewing is emailed over the morning of the ward round. There's clear times with when I expect the care home to have this sent to me by. The list is added by my admin team to my clinic filter by 9:30 a.m. And when I arrive at the care, so I know who I'm going to be seeing, so I can quickly look through the record, check what the plan was from the last time, check whether I need to be doing anything, checking up on anything. It's normally quite a brief glance because I've mentioned I often know the patients quite well, so I don't need to read the record in loads of detail. And then when I get to the care home, I tend to sit down with the nurse, who I know very well, and complete a brief, what I call a board round. So I'll quickly go through the list of patients, check on what issues have cropped up that week, whether they've got any concerns. We then see the patients, prioritise any unwell patients, any new admissions, or anyone recently discharged, and aim to see roughly around 10 to 12 patients per round we're able, although that might not be possible. For example, I do it on a Monday morning, and yesterday I ended up seeing 18 patients, and that's just because there was some complexity that had cropped up, and I've got a few patients on the care of the dying pathway who needed a bit more attention and so forth. So that's how I tend to sort of deliver the ward round, if you like.
So, in terms of the actual clinical work that you do when you're there and the people you're looking after, how do their needs differ from a patient who might be a similar age but living at home and more independently?
So, by definition, they're often a lot more dependent on activities of daily living, if not fully dependent on all their on all their sort of whatever it might be, washing, dressing, bathing, all that sort of thing. Communication can often be a lot more tricky, often because patients lack capacity to make any decisions due to their often dementia or complex dementias, or whether they have a major stroke event or whatever it might be. It's not often it's not that they might totally lack capacity. They may have fluctuating capacity, which can sometimes make things a bit more tricky, because you know that they may have capacity to make a decision about a certain thing, but then they might not have capacity to make a decision about another thing. So you have to be guided by each individual person, really, like with anything. There are often sort of issues with incontinence, which can lead to problems with skin integrity. They're at high risk of pressure damage, often because they're either bedbound or chairbound or whatever. They often pose a higher risk of falls, just generally because of their frailty. That can be quite tricky for care homes to manage. So they often do their own assessments when patients arrive, and this will be part of their nursing assessment in terms of assessing for pressure damage, skin integrity, continence, falls risks. Mental health, as you can imagine, will often be a huge factor here, whether that be challenging behaviour due to the dementia, or
Yeah.
whether that be an evolving depression or anxiety purely because they're more isolated in a care home, because a lot of patients who arrive in care homes, they've been taken out of their own environment, and that can be very distressing
Yeah.
for them, and may often be in a room where they may not be taken out, they might not get a chance to integrate with other residents, and so understandably you can imagine patients start to develop potentially depressive illnesses, and that might be even when they've not had a depression before or whatever. So we've got to be alert to that, because there are things that we can do to try and manage that and help it. They're often more vulnerable. Some may go from being independent to fully dependent, and that's obviously a very, very big challenge for patients, and some people might really struggle. A lot of people understandably will struggle with that. So yeah, lots of differing needs, I would say, to patients who may be of the same age but have their own comforts around them at home, or their families around them at home, or friends or neighbours or people that they've relied on for years, which all of a sudden might be they're not available to them when they're in a care home.
The GP care that you mentioned earlier on, that less is more. So presumably a lot of patients have multiple health issues and they're frail and they might have be on a lot of medication, but the risk and benefit profile of treatment is different. So you take a different approach.
Yes, although there's often multiple pathologies and they often have complex past medical histories, the skill for me, I would say, is doing less, and that can be quite a tricky skill.
Mm.
It's not, it sounds like, oh, well, should be straightforward, doing less. But actually, I think as medics, we are quite inclined, oh, let's add another drug, let's do this, we need to do this, we need to do that, we need to be doing something. And actually just saying, look, let's just stop here. What are we doing? What are we trying to achieve? And trying to take patients on that journey with you can be quite a challenge. Often constricted by time as well, because often these sorts of things require discussion, and that require maybe with the patient if the patient has capacity, or the families if the patient doesn't have capacity, or whichever next of kin it might be.
Yeah.
Very occasionally there's no next of kin, and you might need to involve an advocate, say from the council, to act on or to act in the patient's best interest. So actually doing less can actually be a little bit more tricky.
Mm.
And then you obviously have to convey that to allied health professionals in the form of care plans, which have to be very clear, explaining why further investigations may not be in the patient's best interests. So you're often thinking sort of 3 or 4 steps ahead, I would say. It's a bit like a game of chess, I suppose, because often, patients may say they don't want this, that, or the other. That may not be communicated well, and then a patient ends up in hospital and a load of things done against their wishes. And that isn't, although as a doctor you might think, oh yeah, they've had this, that, and the other done. If that's not what the patient wanted, that actually is not a good outcome. So doing less may not always be the right option, however, and will totally depend on what the problems are. So it's not as though I'm saying always do less. It just totally depends on the individual set of circumstances.
It's looking at the puzzle of like, if this, then that, and but what if, and thinking out
That's it.
possible
Exactly.
scenarios.
That's it. And you can't think of every scenario. And I think some scenarios are sometimes too complicated, but there are a lot of common scenarios that we are aware of that happen in frail patients or patients who are approaching end of life that we can manage. The other sort of example, you mentioned earlier about polypharmacy, and when you asked me the question, Pat, and deprescribing can be quite a complex skill because, as I mentioned, it's good. Doctors are very good at starting drugs, but actually we get quite scared about stopping them. So I think that is a skill again in its own right. And that's where working with your practice pharmacist is very important, because they can be very good at helping you deprescribe and knowing where something might not have the evidence base for that particular cohort of patients, i.e. patients who's got frailty, who's 87 or 88, for example. And it's also less target-driven medicine, Pat. So as you're aware, we have QOF, and our younger patients were there to hit targets a lot of the time and provide the care that good medicine, obviously, but there are targets that we have to meet with QOF. So there's less target-driven medicine in this cohort of patients. So you might relax targets, or you will be relaxing targets for patients. So blood pressures won't need to be as tight. HbA1cs won't need to be as tight. Cholesterols won't need to be as tight. So that involves maybe doing less blood tests and so forth. So that's that discussion you have with the patients. Do you want a blood test every year to check your sugar? Because you've got to think, well, actually, if I'm doing a blood test, I need to act on the results. Whereas if you don't want to add in any more drugs, what's the point in doing the blood test in the first place? So they're the sorts of questions that you need to be asking yourself, and then asking the patients, and having that discussion with patients and their or their relatives or next of kin.
Yeah, absolutely. So you mentioned that there are sort of common themes that emerge, or common scenarios that you might encounter. So could you talk about a patient you've seen recently who you feel might exemplify some of the things you've been talking about?
Yeah, of course, absolutely. So I had a new patient, for example, recently admitted to care home. She was an 84-year-old lady. She had no do not resuscitate order in place, no emergency healthcare plan. She had or has a son living down south who's the next of kin, but there's no other family particularly, and he's not that involved either, which is not an uncommon situation, sadly. And then she had a friend who used to help out when she was living at home, and now occasionally visits her in the care home. She was admitted to the care home under my care due to increasing care needs and not being able to cope at home, largely due to increased frailty, secondary to some of her comorbidities, which I'll just talk about in a second. So her past medical history includes severe COPD. She's on long-term oxygen therapy. She's had a previous fractured hip, and had a hip arthroplasty done a couple of years ago. And all of this had a knock-on effect to her sort of general degree of frailty and poor mobility. She's got type 2 diabetes, ischemic heart disease, arthritis and polymyalgia, also has a degree of vascular dementia and some upper GI problems as well. And her mood is also quite low. So functionally, she's mobile with a delta frame and requires assistance with washing and bathing and dressing. Doesn't have a particularly good BMI, partly because of her COPD. She takes a whole concoction of medication. So she takes salbutamol, inhaled therapy, seretide, tiotropium, takes some medicine for osteoporosis, Adcal and a bisphosphonate. She's on a long-term steroid for a polymyalgia, although only a low dose, a couple of milligrams. She's on maximum dose of metformin. She takes quite a high dose of glycoside for her diabetes. She's on aspirin, mirtazapine for her depression, 30 milligrams, bisoprolol 5 milligrams once a day, paracetamol 1 gram 4 times a day, and she takes codeine 15 milligrams 4 times a day for pain. So the first thing I tend to do with this sort of patient on arrival is check with the nursing staff whether there's been any acute issues. And my general approach would be to review the patient's record ahead of the assessment by me. But if I don't have the record at the time of doing my initial assessments, I might have to review that later. But hopefully the record is there, but that isn't always the case. But sometimes I use EMIS, so you do tend to get an EMIS to EMIS transfer. But if other practices are on different systems and she's moved over from a different practice, I'll normally get one of my administrative team in reception to get a summary of the patient's record from the previous GP surgery and get that scanned into at least until I've got the more formal record sent over.
Yeah.
So I'll normally identify or create a problem list initially, and that'll be generated by some of the acute issues that might be going on. So for this particular scenario, the problem list for me was, and this is a patient I only reviewed very recently, so she's got quite complex COPD and she's on long-term oxygen, so that's an acute ongoing issue. She lacks capacity with her dementia, so the staff in the care home have applied for a deprivation of liberty safeguarding, or a DOLS.
Yep.
As it's also known. There's polypharmacy there, as I've just listed the medication. She's on a huge amount of medication, which hasn't, from what I could see, been reviewed recently.
Right.
There was no DNA CPR. There was no emergency healthcare plan. The staff at the home, since she's arrived, reported she's been quite constipated. She's been quite lethargic, and she's also had intermittent swallowing problems. So already I've got quite a significant, chunky problem list that needs a lot of attention. So I'll normally discuss things with the patient, and in this particular scenario, it was quite apparent to me that she was quite lethargic, as the care home team had been reporting, and I couldn't really get much in the way of a history from the patient due to her dementia. So that touches on some of the issues that can arise with patients with frailty dementia, where communication can be a bit of a problem. So you're relying largely on the collateral history from the care home team, and also maybe some family members, depending, to give you some information on what she might have been like at home and so forth. So you're using a bit of a triangulation approach, if you like. So then it's about sort of medication. Now, there'll be a bit of, normally I would do a little bit of this, but I normally leave it to my pharmacist to review the meds in a bit more detail. But if there's anything obvious that I can adjust, then I'll tend to do that in my initial approach. So things that I'll be thinking about, what's her inhaler technique like with a COPD? Does she need the osteoporosis medication? She's got swallowing problems, which is on a bisphosphonate. Could that be contributing?
Yeah.
What are her blood sugars like? She's got diabetes. She's on quite a high dose of glycoside, which we know can cause increase the patient's risk of hypoglycemia. In this sort of particular type of person with frailty, low BMI, I'm thinking you're on quite a high dose of glycoside. Is that really needed? Does she need that much analgesia? And why is she on aspirin and a beta blocker? So there's lots of things there with even just the medicine alone to be thinking about.
Yeah. Yeah. Sounds like that alone is a kind of like a task to be addressed, presumably over time.
Time, but also again, just coming back to using using your practice pharmacist part.
Right.
So having link pharmacists. So when the way we have it set up is when a new patient arrives, they'll all get a review, obviously from myself. They'll get one from the practice pharmacist as well, who might be able to do a bit of a deeper dive into why certain medications were started, when they were started, if it's not obvious, and actually having that discussion about do they need to carry on. So on reviewing her notes, I could see she didn't have a formal diagnosis of ischemic heart disease. And angina was diagnosed many years ago when she was in her 60s by her GP at the time. But actually, though, in those days, there was no formal testing. So she wasn't popped on a treadmill. There was no such things as perfusion scans, CT coronary, angiogram, so forth. So she was actually it was a clinical diagnosis. She was just started on aspirin, a beta blocker on the back of that. So that was already a question mark for me as to whether she needed to be on the medication. Osteoporosis, she had a DEXA scan 5 years ago, but we know she fractured her hip 2 years ago. So that was a bit of a, which one do we need to continue anything there? Do we just continue the calcium now that she doesn't mobilize much, or do we leave the bisphosphonate on? So that was something myself and the pharmacist discussed. She had polymyalgia diagnosed by a GP 2 years ago, and she'd been on a weaning course of steroids since. She's now down to 2 milligrams, but that had not been reviewed for six months. And I could see she'd had bloods 4 months ago by her previous practice, and her HbA1c was quite tight at 50, but otherwise her bloods were okay. So quite a lot of things there to juggle. So I agreed. I set up a meeting with her son, which I booked a double appointment for, and discussed the son's concerns, who was largely happy with his mum. And then I discussed all of my concerns with medication and some of the things that I've just been talking about there. So with the son, I actually agreed on the following plan, which was to stop the aspirin, stop the bisphosphonate because it could be contributing to the swallowing problems, stop the glycoside to keep an eye on her blood sugars. So we came up with a plan for that. We agreed that we'd be doing annual bloods still, but just kidneys, USANEs and HbA1c, no additional bloods needed. The care home staff to keep an eye on her feet, so regular foot care, and do that every year as part of a diabetes review. We thought, why don't we reduce the paracetamol down to 1 4 times a day instead of 2, stop the codeine and keep it just as PRN. So as and when, because my question was, is that possibly linked to her fatigue and constipation?
Yeah.
She's been medicated. Make sure her bowels are moving with regular laxatives. The son was keen to keep the antidepressants as it was because he felt that she'd responded quite well to that when she first went on it. And although I was wondering, could it be contributing to the lethargy? Because we've stopped the codeine / reduced it, we thought, let's just see what the outcome of that intervention was first. We'd keep the inhalers as they were because they were helping with her COPD. Add in a rescue pack for if she did have an exacerbation of her COPD. So then there were some antibiotics and steroids to hand, with a little bit of training to the staff on how to use those. Then we're going to continue to wean off the steroids with a view to stopping them in the next couple of months. We also touched on a DNA, although that was quite a complex consultation and quite a lot to cover. I didn't want to overburden him as well. So I touched on resuscitation and emergency healthcare plan, but we agreed that probably wasn't an appropriate time to discuss that. So I arranged for a further discussion with him a couple of weeks later. So that was the kind of plan that we came up with. So we rationalized a lot of medication. It felt like a very complete, holistic consultation with the son.
And can you talk any more about what's happened since then and what the effect was of the changes that you made?
Absolutely. So I still haven't picked up the consultation about the care plan and the DNA CPR. So in linking to this case, I've asked the son if he wants to, he can pick it up with the care home team, so have that discussion with them if he wants to do that as well. So that's still pending. She has actually been a little bit more bright and alert since the codeine was stopped. She hasn't needed it. She's been okay on a paracetamol. The physio's been in already to have a look at her and try and get her out of bed, and she's been mobilising a little bit better. So there's still a little bit of restriction because of her dementia. So obviously mobility's still not great, and she forgets to use a frame and that sort of thing. So we've got to be a little bit careful in balancing that with the falls risk. But overall, she does seem a little bit better. And whether that is because we've stopped the codeine, or whether it's purely because she's adjusted a bit more to her environment, or my gut feeling is it's probably a combination of all of the above, really. And obviously that she's not constipated anymore as well. So I suspect all of that has contributed to a slightly increase in her well-being within the care home. So actually she had been over-medicated with her anti-diabetic medication.
That's great, because obviously she's experiencing better quality of life with the potential to mobilise and to have some social contact in the home. And also,
Absolutely.
From the NHS's point of view, you have deprescribed, and then that if everybody does that where appropriate for all patients, then I guess NHS resources are saved, which is also a good outcome.
Absolutely, yeah. And the other thing is my pharmacist will pick up the part of that in a few months. That as part of her role is that she'll also just set up a review with the care home in around 6 months' time, just to check that there's been no significant changes. I mean, I'll be seeing the patient every 5 weeks, I've already mentioned. So if there's anything major, I'll be able to pick up on that. But my pharmacist will also be able to pull to check that bits of bloods have been done and so forth, which might be something I might not get a chance to do if the patient's develop an acute problem or something.
Yeah. Yeah. Oh, that's really, really interesting to hear about that case. And I know that when we were talking about lipids on the previous podcast, you said you often got asked a question about statins and frail older people. Is there another, out of the people that you often see in nursing homes, is there another kind of standout medication that you'd say worth looking at in this cohort?
Yeah, I think there's lots parts really, and most of my colleagues who are listening to this will be dealing with this sort of thing every day. Really, it obviously doesn't apply just to care home patients; it's frail patients who are at home or in other sort of institutionalized care. But the things like anticholinergics, anti-diabetic drugs, as I've just been discussing in that particular case, risk benefits of anticoagulation, risk benefits of certain cardiac medications such as antihypertensives. Again, it goes back to that less is more, because we know that if you controls too tight, as I was touching on earlier, that can actually, there's evidence to suggest too tight a control for certain things can increase morbidity and mortality. Antihypertensives are a good example of that. If you over medicate, increased risk of falls. We know falls lead to injury. Injury could be severe enough to cause even death, bone fractures or whatever. So there's all sorts of issues that come with certain groups of medications. There's pain relief. As I've just been discussing with that patient, she was over medicated with codeine, and that led to lethargy, constipation, drowsiness that increases risk of fall. So many, the list goes on really. There's other pain reliefs like anti-inflammatories. Got to be careful with sedatives, antipsychotics in case they're really, really needed. And also caution with certain things like antidepressants. Although I'm not saying everyone who comes into account, all of these things need to be stopped. It's got to be weighed up on the pros and the cons of these drugs, and that conversation has to be had with the patient if possible, or their next of kin and relatives, and really, really thinking hard about, does this patient really, really, really need this?
Yeah. Yeah. So finally, if a GP is keen to do more in this area and improve quality of life for nursing home residents, what do you think their learning needs might be? How could they meet those?
Sure. I think a lot of GPs will be have a good amount of frailty experience, I suspect, just given the fact that that's a lot of the work we're dealing with on a day-to-day basis. But if you're looking to improve your experience, take the lead in your care home and care home work, or is it a role that someone else is doing which you could potentially take over? Could you swap the roles around? There are lots of frailty modules out there that I'm aware of. Obviously, I've done some articles for yourself, and there's modules there which hopefully people have found useful. I know the British Geriatric Society have a good amount of modules on their website. There is a diploma that you can do in care of the elderly if people are interested. And it's just looking out for those sorts of events, I suppose, that might be available in frailty. As I've mentioned, there's PCN frailty meetings that I am involved with, and just being aware of your local enhanced service, because we all have a contractual obligation to provide some structured care to our care homes, which was introduced a couple of years ago. And so just being awareness of what might be included in that enhanced service, making sure you're using the correct codes when you're coding records, the correct sort of dementia templates, doing any sort of exception reporting for certain chronic illnesses if it's not appropriate for that group of patients. So if there's any registrars listening as well, can you shadow your colleagues? Can you share the work? As I was just discussing earlier, that one of my F2 colleagues does. Can you take on that care home for that rotation that you're within your practice? Can you attend a PCM meeting with your trainer on frailty or so forth? So lots of opportunities, I would say, Pat, out there to improve frailty knowledge and be involved with frailty, particularly if it's an area that interests you.
Brilliant. And at the bottom of the podcast, we'll signpost some of the modules that you've written for us about nursing home residents, kind of like case scenarios. And we've also got a frailty clinical review in the pipeline coming up. So there's quite a lot of e-learning on MIMS Learning alongside the other opportunities that Pip's mentioned there.
Just the only thing I would say is it's an exceptionally rewarding role, and that ability to provide that continuity is what makes it rewarding, and getting to know that group of patients and their families, because often they've lived very long lives, and Some of them will have that, will be able to share some of that information and their lives with you, and that can be quite fascinating, really.
Yeah, quite amazing people. Absolutely. Great. Well, thank you. Thank you so much. We'll have you back again. But in the meantime, I'd just like to say thank you very much for going through all of this in detail with us, because I think it's on the agenda in a big way. And it's great to hear what you do in your practice and in your local nursing home to provide great care. So thank you.
No, thank you for having me, Pat. Thank you so much.